Well, welcome back. Glad you're sticking with us after 3 full days. This is pretty much the last of kind of the home stretch here. And for this presentation, we're doing the reimbursement landscape after the public health emergency. This is actually the second of a three-part series. So May joined us earlier on before the summit even started to do the first part, which was what had changed during the public health emergency. If you stick around after May's presentation, we're going to talk a little bit about the third part, which is our state meetings, and give you a little bit of a landscape of what's going on at the state level, and that will be coming up after the summit is over. So please stick around with us after this presentation. This presentation is really going to focus on more of the federal, a little bit of an overview of the state piece. And giving us this presentation is May Kwong. She is my peer at the National Telehealth Policy Resource Center based out of the Center for Connected Health Policy out in California. And so without further ado, go ahead, May.
Thank you, Kathy, and thank you everyone for attending this morning, this presentation. I really appreciate the invitation that MATRC extended to me to provide this presentation for you on what the future of the reimbursement landscape may look like after the public health emergency. A few disclaimers before we begin our talk. Please note that any information that I provide today is not to be considered legal advice. It is strictly for informational purposes. CCHP always recommends that you seek out legal counsel if you want a formal legal opinion. Also, if I happen to mention a company or show some type of product, know that neither I nor CCHP has any type of relevant financial interest, relationship, or arrangement with such a company. A little bit of information about CCHP. We were established in 2009 in California as a program underneath the Public Health Institute to really be a California telehealth policy organization. An opportunity to become the federally designated National Telehealth Policy Resource Center became available in 2012 through a grant through HRSA. CCHP applied for that, we got it, and we've been serving in that capacity ever since. We work with a variety of other funders and partners on the state and federal level on various telehealth and connected health projects. We're also the administrator for the National Consortium of Telehealth Resource Centers, which is made up of the 14 telehealth resource centers who are underneath the same grant program as CCHP and MATRC with HRSA. As I said, there are 14 of us. There are 12 regional resource centers that cover specific states, and then the 2 national. CCHP is the one on policy, and there's another one on technology. And we're also the convener for a group out in California called the California Telehealth Policy Coalition, which is made up of over 100 statewide groups and individuals who are interested in advancing telehealth policy specifically for the state of California. So as was mentioned in my earlier talk, if you attended that, and I'm sure everybody knows, there's been a lot of policy changes, both on the federal and state levels regarding telehealth. In those early days of COVID-19, those first couple of weeks, there were changes almost on a daily basis as to like what was happening with the policies. A lot of them were to expand and allow for greater utilization of telehealth. And the reason for that is because pre-pandemic, there were a lot of barriers or a lot of restrictions on how you can use telehealth as far as programs such as Medicare and Medicaid were concerned. So that was why we saw so many changes happen in such quick succession during those early weeks, because there needed to be a lot of changes made depending on which jurisdiction you were in. None more so than Medicare on the federal level, which was actually one of the most restrictive telehealth policies out there before the pandemic. Now, but as you can see, this is your 100,000 level sort of overview of what some of those changes were. So obviously not a lot of details, but you can see on at least the specific policy issue that those changes focus in on. There were some commonalities between what happened on the federal and the state level. Again, the details vary as to like the specific change, but there were certain areas that were common that the policy changes had to hit on, because those were usually where you found some sort of limitation. The one very common thread that they all have, though, is that these were temporary changes. So we knew going into COVID that these changes likely weren't sticking around. And a lot of the times they were connected with a public health emergency, saying that these would only stick around, these temporary changes, until the public health emergency was declared over. Or in the case of sometimes on the state level, they actually had a specific expiration dates, such as until June 1st of 2020. But for the most part, most of the temporary changes were tied to the federal public health emergency declaration. So for a while there was that concern because the public health emergency needs to be renewed every 90 days, essentially. And there was a concern of like, what will happen if it expires? There's that abrupt shift back to pre-pandemic type of policies, and a lot of investment for a lot of providers, a lot of organizations were made in at least getting these telehealth programs stood up very quickly in response to the pandemic. So that's what we're going to cover now as far as what is likely going to happen when the public health emergency is declared over. Now, as Kathy mentioned, this is going to primarily focus on the federal level because I understand there are these state meetings that are taking place, though I'll do a very sort of general overview of what's going on in the state, but really going to focus in on what was happening on the federal level, particularly Medicare. Now, the reason the hard focus or the main focus is on Medicare when we're talking about the federal level is because a lot of the telehealth policy that exists on the federal level really is about Medicare. There are other policies. For example, there are prescribing policies related to telehealth underneath the Ryan-Haight Act. There are some privacy policies as well that were temporarily waived with like HIPAA. But for the most part, the very specific telehealth policies centered around Medicare and the changes, or at least the temporary changes that were made there. And for the policies, this goes back to like the issue areas that I was talking about a little bit earlier at the beginning of this talk. For the issue areas, the reason you see sort of commonalities around there is because a lot of the policies that exist around telehealth is around reimbursement, what's paid for in Medicare, what's paid for in Medicaid. And reimbursement policy itself can be basically boiled down to 4 elements: service, location, modality, and provider. There's usually something in that reimbursement policy that touches around one of these 4 areas, and usually is a limiting thing. So for example, you could have a policy in a Medicaid program that says this Medicaid program will only reimburse for what type of service, mental and behavioral health services, where's the location of the patient at the time service takes place, when the patient is in a clinic setting, such as a hospital or a doctor's office, what modality is being used, when it's being used, provided via live video, and who's the provider providing it, when it's being provided by a psychiatrist or a psychologist. So that's how a lot of reimbursement policy, both on the federal and the state level, is built. It's why these are like typically the areas that you'll see something written about them, creating usually some sort of limitation or restriction. So when COVID-19 hit, that was like the 4 sort of main areas that were moved upon in order to like create temporary waivers in order to allow telehealth to be used more expansively. And Medicare did some sort of change to each of these 4 elements. Now, the thing though, with Medicare and their telehealth policies, it is not something that CMS administratively can decide to make changes on on their own. A lot of the Medicare policies are embedded in federal law. So you literally require an act of Congress in order to change that. So CMS had to wait for Congress to act in order for them to make some sort of change in response to COVID to one of these 4 elements. The one area where CMS does have a lot of flexibility and a lot of oversight and choices to what they want to do is service. So they can decide what type of services essentially to allow to be provided via telehealth and reimbursed for it. But the other 4 elements, the location, the provider, the modality, they had to wait for Congress to act in order for them to make any type of changes at all. So Congress did act and gave them at least like the flexibility to make changes, or they gave a direct sort of instruction to like expand a particular element or category. So all 4 elements saw some type of change happen in the Medicare program during the pandemic. So for services, they added about 140 different service codes, additional service codes to like the eligible telehealth reimbursement list. For location, Congress allowed the expansion of services to take place without the geographic and location limitations. So it could take place in an urban area now, and it can also take place in the home. Very important during this pandemic as people were sheltering in place. The modality, there was a little bit of flexibility given, and what was opted to be done was to allow audio only phone. And that was recognition that not everybody had that connectivity to like video. So audio only phone was allowed. But interestingly, no sort of other modalities as far as remote patient monitoring or store forward were considered underneath their telehealth policies to expand there. So it was really just audio only phone that was sort of the change on modality. And then provider, basically, CMS was allowed to open it up to like all eligible providers who are Medicare enrollees who are eligible to provide these services acting within their scope. So basically open it up to all of them. So all these changes were made during those first couple of weeks of COVID. Of course, greatly expanded how Medicare was covering telehealth delivery services. But again, we were still in this temporary phase. These were only there until the public health emergency expired. So, what will be sticking around? There were a couple of other changes, that happened that weren't related to reimbursement. There were some HIPAA relaxations to allow utilization of like platforms that may not have been HIPAA compliant. I will caution folks to say that relaxation was basically, the Office of Civil Rights saying that we will exercise discretion when looking at this case. So there was not an entirely explicit free pass. They were just saying we're exercising discretion in like the choices that you're making for the technology. So there's not necessarily a guarantee that they wouldn't hit you with a HIPAA fine. They're just saying we're exercising discretion now. I don't think they will, especially like for those early couple of months, like look back then and look at that. But I do want to point that out, that was not like an absolute guarantee that they wouldn't take some type of action down the road. So if you are still operating underneath that HIPAA relaxation, I now, when things are a little bit more settled now, you may want to sort of reassess your program to make sure you're in HIPAA compliancy as if the waivers did not happen. Then some of the other changes, again, not related to reimbursement that are out there, was the DEA, the Ryan Haight Act exception. So for those who are not familiar, controlled substances is essentially controlled by federal law. And the shorthand that you'll hear people say is like the Ryan Haight Act. That's because that is where it's the act where the specific telehealth element was in, or the specific telehealth policy was in. So people use the shorthand of saying Ryan Haight Act. And the telehealth exceptions for using telehealth to prescribe a controlled substance are about 6 narrow exceptions. So they basically say that the patient needs to be in a DEA registered facility or physically with a DEA registered licensed physician when the telehealth interaction is taking place. But one of the exceptions is also when a public health emergency is declared. Since a public health emergency was declared, this exception kicked in. Once that public health emergency is over, that exception is going to obviously fade away, and you're left with really just those narrow exceptions on how to prescribe a controlled substance. So that is something that is probably not going to change because the narrow exception was already in federal law. It kicked in with the public health emergency. When it goes away, it goes away, and you're still left with like the other sort of like narrow allowances for prescribing controlled substance when you're using telehealth. But the question is, as we're all here to say, is like what has been made permanent, what's sticking around. So there are 2 ways of making things permanent. You can go the administrative route or you can go the legislative route. And as far as what's been changed so far that is going to stick around, been made permanent after the public health emergency is declared over, really what's only happened is the administrative route. And I said earlier, as far as like the 4 elements where policy, reimbursement policy is structured, CMS only has control basically over the types of services that are covered. So CMS did make some permanent changes with their last physician fee schedule. For those who are not familiar, the way CMS makes changes to the Medicare program every year, they go through what's called a physician fee schedule proposed regulations. So these are a set of regulations that they come out. They issue essentially their draft, their proposal in the summer, around July, early August. They have, I think it's it's about 60 days where they need to take public comments, or maybe it's 90 days, but they have a period of time where they need to take public comments. The public send in their comments. CMS has to respond to them, and then they publish their final proposal at the end of the year, like in November, early December. And then the final proposals are the policies that will kick in the first of the following year. So those are the changes that are permanent to the Medicare program until like the, following physician fee schedule proposal if they happen to make any type of changes. So in the one that was issued, the physician fee schedule that was proposed in 2020 for the year 2021, they did make some of the temporary COVID telehealth policy changes. They did make some of those, propose some of those to make those permanent. And for the most part, again, the telehealth policy changes that around reimbursement centered around the services that were allowed. So in the 2020 proposal that kicked in for starting January 1st of 2021, CMS proposed to put on the permanent list about 9 services that were on that temporary telehealth COVID services list. And then they also created this other sort of holding bucket for about like a couple of other services that are on the list. And this holding bucket essentially was basically temporary codes on the COVID list that they would put in this temporary holding bucket and said, in the year that the public health emergency is declared over, these particular codes in this holding bucket will still stick around until the end of the year that the public health emergency is declared over, because we're not quite sure if we want to keep these around. So we want that additional time to examine them to see if they should be put on the permanent list. So it's this sort of like half step of it. They're not quite permanent, but they don't disappear immediately when the public health emergency is declared over. They're sticking around so CMS can kind of examine them to see if they're worthwhile being put on the permanent list. There were a couple of other changes that involved telehealth policies that were temporary waiver policies that they not necessarily made permanent, but maybe, the concept of them was made permanent, but they were slightly tweaked. So for example, one of them was the amount of visits that can take place in a skilled nursing facility. So before the pandemic, it was 1 telehealth visit every 30 days for a resident in a skilled nursing facility. For the pandemic, they eliminated the frequency limitation. So for the change that CMS proposed and made permanent was basically saying, well, you can have 1 visit every 14 days. So they narrowed down the window, or they shortened the window of how frequently you can have those visits, but there was still a frequency limitation there. So there were a couple other changes like those as well. But as you can see, for the most part, not any of the big changes, not anything related to the geographical limitation or to like the list of providers. And that's because you have to go the legislative route with that. As I said earlier, a lot of that is embedded in federal law. You really need Congress to act. So did Congress act? And the answer is no. So Congress has not acted so far in making these temporary changes permanent. What they have done is they've done a couple of other things with telehealth policy, but none specifically related to those temporary changes. Like, for example, in the Consolidated Appropriations Act, which you can go to next, which was passed in December of 2020, they added another eligible originating site, which was a critical access hospital or other rural health facilities with less than 50 beds. So you have like another originating site that is eligible to be a telehealth originating site underneath the Medicare program. They also did one thing that was very, very unexpected in the way that they crafted this, is that they would allow for mental health services to be covered via telehealth without the geographic limitations and allow the home to be an eligible site. But they made a caveat in that there needed to be 1 in-person visit with the telehealth provider at least 6 months prior to the telehealth interactions taking place. So that in-person visit is really the surprising thing, because that has not been a requirement before. Now, this does not mean like all mental health services underneath Medicare then will require this in-person visit. It's only when you're trying to come underneath this exception of like, allowing the home to be an eligible site, or you're trying to get out of geographic restrictions. So if you're still underneath that original model of like, I go to a clinic, they connect me with like a telehealth provider for like a mental health services, that telehealth provider does not need to have that in-person visit if they're like in one of these eligible originating sites that are on the original list, such as clinic, hospital, doctor's office, like that. But if you are trying to like avoid the geographic limitation or the home restriction, you're going to need that in-person visit before you can provide services via telehealth. So that was a bit of a surprise there, because again, that was not on like the temporary COVID list of things, and it put a twist on something that we hadn't seen before, a requirement of an in-person visit for telehealth. And then there were some broadband things as well. So Reconciliation Act has been like the latest congressional movement that had some telehealth stuff. It essentially was like funding for certain things like grants and so forth. So again, no policy changes to the telehealth policies that we are seeing that have been temporarily relaxed. So again, it's more funding there for specific things, which is great to see, but we're not seeing like the major policy changes. What are other possibilities, other routes where we may see policy changes? There's been a rash of like federal bills related to telehealth that have been introduced. I'm going to go over a couple of them. There's the Schatz bill, which is probably one of the largest ones, Telehealth Modernization Act, and it keeps some of the temporary waivers in place, such as like expansion of originating site. It gives the HHS secretary, the power to expand the list of eligible providers. So it doesn't say like, it's not a direction in the bill to like immediately expand it, but it gives the power to the secretary to go ahead and expand it without having to wait for Congress. And then it allows FQHCs and RCs to continue to act as like service providers, which was one of the major temporary changes that were made in response to COVID, was allowing them to be distant site provider. Some of these, when I did the PowerPoint, they did not have the full text available. So I'm just going by like the summary, such as the Rochester bill, HB 1332, to make permanent certain telehealth flexibilities. I'm not quite sure exactly which ones that it contains because the text wasn't available yet. But it's really there for you to see like, you know, the different bills that are being introduced that are looking specifically at this area. There's the Dingle bill, which is the TREAT Act. This is around the licensing issue. So this would create a temporary licensing during like the public health emergency to allow not the requirement to like get a license to treat patients in another state that you are not licensed in already. And then like certain requirements that they would have to meet. So there's that interest as well on interstate licensure that is Congress is looking at too, which again is a bit of different change because that has not been sort of like a major sort of federal issue. It's been left up to the states. They've kind of like before the pandemic taken a hands-off approach to that. But now they are really interested in looking at it. Again, these did not have text available, but so I'm going by the little summary there. So the Welch bill, the reason I pointed this out because like a lot of other bills, there's a specific call to collect and analyze data. My apologies there. Collect and analyze data. And that's going to be a major thing regarding telehealth and regarding telehealth is that call for data. It's always been something that has been top of like provider or policymakers' minds is like the need for data, need for information for them to like make their decisions on like what to keep around. So we're going to see that I think a lot more on the state and federal levels of like, you know, just these demands for data of like, does this work? Is this as good as, you know, in person type of thing? Then there's the Morawski bill, is like parity and coverage of mental health and substance use disorder in private insurance plans, which was interesting to see. You usually see these commercial plan type of bills more on the state level, you know, parity bills on coverage and reimbursement. It was interesting to see that on the federal level. So I wanted to call your attention to that. And then a lot of these are also like the HR 1647 bill, cause of using telehealth to treat mental health and substance use disorders. So keep in mind, during the pandemic, there were actually 2 public health emergencies going on. Not the one with COVID got a lot of attention, but there was still like the opioid substance use disorder epidemic that, you know, had been declared earlier or had been identified earlier before the pandemic. That was still going on and also probably was exacerbated during the pandemic because people were probably less likely to get the the services that they need to treat that because they were sheltering in place. So looking at telehealth to do more with treating people with mental health issues or like substance use disorders. And then maternal health bills also getting a lot of attention here. So there's a Black maternal health bill that has one of the best sort of titles I ever saw for a federal bill, the Omnibus Act of 2021. So it was not specific about telehealth. Telehealth is an element of this particular bill, which is, again, what we're also seeing is like we may see larger bills that have a telehealth element in there. So these are only like a small sampling of bills. So which one of these is likely to get passed? And I would say, again, no sort of insider knowledge here. This is just me looking at the historical sort of evolution and what has happened to bills in the past. I would say probably none of these have a chance of getting passed, like, or very only possibly one or two. And the reason I say that is like historically, telehealth bills have a tendency to go nowhere. But what can happen is that elements from these bills can be plucked out and put into larger bills. And that may be a way of getting some of these telehealth policy changes like made permanent. But as a bill like, for example, the Telehealth Modernization Act by Schatz, a full telehealth bill like that getting passed, I'm not quite sure that that will happen. And it's not because telehealth is not popular, that it's not a bipartisan issue or anything. It's just that it's not historically bit what's happened. What we have seen though is like elements of it have been plucked out and like put into larger bills. And another reason I would say that I think there may be some hesitation and why I don't think like these telehealth specific bills will get passed is because I am sensing sort of a bit of hesitation from policymakers, at least on the federal level, in telehealth and like pulling the trigger and making something permanent. I would have thought that if anything was going to be made permanent, they would have taken advantage of the Consolidated Appropriation Act passed back in December of 2020. That was their opportunity to put something in, again, a larger bill that had a telehealth policy in there to make permanent, and they did not take advantage of that. And then there was nothing really in the Reconciliation Act except for like grant funding for certain specific types of projects or elements and like how to use telehealth. So there were these two opportunities that I thought something would be slipped in and nothing was. So I think there's a bit of a pumping up brakes or a bit of hesitation by federal policymakers to take that extra step to say like, yes, let's go ahead and make this specific thing permanent. And what other reasons is that sort of, making me think that? It's a couple other things that have happened on the federal level as well. So on the March 2nd, earlier this month, there was an energy and commerce hearing. And I don't know how many people sat in there and like listened to it, but it was on the House side. It was the Health Subcommittee of Energy and Commerce. And in listening to like this 4.5-hour hearing, there was a lot of focus around, fraud, like concerns that telehealth would encourage fraud, what's going on with fraud. There was a lot of concerns about allowing audio only to continue. And there were a lot of questions of like, well, is telehealth as good as in person? Is it going to be that? So all this hesitation, these were, as I said, it was a 4.5-hour hearing. That was the majority of stuff for 2 hours to begin with. And then finally somebody brought up the thing of like, well, are we creating health disparities or like, would somebody suffer if we didn't allow audio only? Would certain communities suffer because of that? So the fact that wasn't where they automatically went to of like, if we roll back the telehealth stuff, is this going to hurt patients? But they immediately thought about fraud. They immediately thought about cost. They immediately thought about, is it good enough? Signal to me at least that some of the members at this hearing were having some hesitation about telehealth, some sort of, second thoughts of like, well, it was maybe good for this temporary need here, but perhaps we shouldn't be so hasty into like making some of these permanent. Fraud, as I said, was, a big issue that was like discussed a lot at this particular hearing. So there was also Office of Inspector General report on fraud that came out. You probably have seen like over the months, like a lot of articles saying that, there's been like telehealth fraud in the Medicare program. Like, they caught somebody who's like defrauded about $1 billion or something like that. These very sort of like eye-catchy headlines. OIG had to come out with a statement saying, like, you may have seen these stories. It's not telehealth fraud. It's more telemarketing fraud. So basically what a lot of these sort of like, telehealth fraud stories in the news have really been more about, yes, there was a telehealth element in there, but it was not providers who are submitting reimbursement for services provided via telehealth. That was just sort of like an element around this whole scheme where they were doing more telemarketing fraud. So even the OIG has said, like, we've really not seen any fraud with telehealth so far. It's really been more around these other types of fraud that we've seen, but we are looking into it. So that was another element out there. But like sort of like those eye-catching stories, I think probably spurred some of the questions that we heard in the Energy and Commerce hearing. And then the other sort of like, federal development that happened just even like this month, so the last stuff actually happened in the month of March, was the MedPAC report. Now, for those who are not familiar with MedPAC, they are this nonpartisan commission that advises Congress on the Medicare program. They have to issue regular reports like every year to Congress on like sort of their recommendations and examinations. And this time, the report they released in March, they had a chapter on telehealth. And they had some recommendations for this. They actually recommended that after the public health emergency is declared over, keep some of the temporary stuff around. And what they said, like, have like audio only around, but only for like a limited set of services. Allow some of like the services on the temporary list to continue, and allows the extension of some of the location relaxations as well. But they also had other recommendations. They said, well, we also recommend that you do these things in order to combat fraud, such as, requiring an in-person visit before you prescribe expensive durable medical equipment or expensive lab tests. So again, we're seeing like now the reoccurrence of a suggestion of like having that in-person visit before some telehealth takes place. So that links back to what I said was in the Consolidated Appropriations Act with the mental health services. So what's also missing from this list, though, you see, as we go back to like, what were allowed temporarily during the COVID extension, is they did not have a recommendation of keeping the expanded provider list. That is missing from this list as well. And they had like very limited exceptions for what they were recommending. And they were saying that these things should stick around temporarily beyond the public health emergency an additional 1 or 2 years. So they were not recommending that this be made permanent, but that it just be kept around for 1 or 2 years, again, to like, gather enough data to see if it's as good or worthwhile to keep around. So I actually think that it is possible that this may be the track or the route that the policymakers may take on the federal level, is that we'll extend things beyond the public health emergency for a temporary period of time on certain things, just to see if we want to keep it around permanently. So that allows them an additional opportunity to like gather data. It also allows them to delay making a permanent decision right now, because there are so many other things going on. They may want to focus in on those before they focus in on telehealth. So I think that is quite possibly a tack that the federal policymakers may take. So state, and just really quickly, because again, I understand that you are going to be having more state-focused conversations, and states do vary. States do vary from state to state on what they're doing, what their policies are, what they're considering. So this is like very general sort of overview here. So CCHP looked in 2020 during a period of time to see what were permanent state telehealth changes, and we found that 31 states from July to August had made permanent changes, but mainly through like administrative channels, through their Medicaid program. So not necessarily passing a legislation. And also we weren't 100% sure if they were in response to COVID. Obviously, if it said something about a pandemic or COVID, it most likely was a change related to COVID in some way. The change was spurred by COVID perhaps. But there were some permanent changes that, that didn't have that identifying marker. So we don't know if those were already in the works before the pandemic started with that particular state. Some of the changes that happened was basically, adopting the policy of a reimbursing for audio-only phone in their Medicaid program, making it very narrow. So, for example, not allowing audio-only phone to provide all sorts of services, but maybe for just mental behavioral health services. a lot of clarifying policies. So clarifying that they allow the home as an eligible site in Medicaid, and also clarifying what policies around FQHC, such as yes, they can be a distance site provider, or yes, we'll pay the full PPS rate, or allowing certain providers underneath FQHCs and RHCs at least to qualify as distance site providers, if not like the entire entity of FQHCs, RHCs. Trends that we are seeing now in legislation that's being introduced, a lot of mental health bills in SUD, never a big surprise, but I think that's taken on like, a little bit of added urgency with like the pandemic. Removing the telephone exclusion from definition of telehealth or telemedicine. Before the pandemic, a lot of state jurisdictions had on their books their definition for telehealth or telemedicine, an explicit exclusion for audio only phone. They would say like telehealth or telemedicine means this and does not include phone, email, and fax. So an explicit exclusion that's being removed to leave it a bit broader. There are private payer bills that are being introduced again, and then licensure bill. Again, licensure became like it's always been a big issue, but it got elevated during the COVID-19 pandemic as well, because people were getting stuck in states because of, travel limitations or just sheltering in place. So licensure became like a big issue. And then board actions on telehealth. So directions to like regulatory boards of like, do more guidelines, do more explicit things on what your licensees need to know about telehealth. And then also what's also going on at the state level are a lot of discussions on what to make permanent. We've seen some states already take some actions. We're also seeing hints of states saying like, we are going to make a decision later this year, like in July of this year or September of this year, of like what our policies are going to be permanent going forward after the pandemic. What can we expect? As I said, I think like with the federal, likely a temporary extension of some of the telehealth waivers beyond the pandemic. Fraud's always is going to continue to be something that people are going to bring up, so just be aware of that. And more calls for data on, whether this is like just as good in person or audio only. If they're talking audio only, they might say, is this as good in person and live video? So that's like an interesting thing. And that audio only issue is going to continue to be an issue because there is, I think, recognition for some policymakers at least that may be the only way somebody can get a service, but what do we keep around to allow that? Because we're not quite sure if this is as good as in person or via video. And then there's the possibility like that expansion of the type providers who provide services may not be one of the temporary extensions. Again, it was very surprising to me that the MedPAC report did not talk about expanding that list of providers, keeping that expansion around temporarily at least. So that is a concern, especially if you're a community health center who was allowed to be that distance site provider during the pandemic. On the state, what to expect, we'll probably get a better idea of states. States may actually move a little bit faster than the Fed, so there's going to be at least some permanent changes that we'll know what will be taking place in states. The states that haven't made any changes, I could see them following the Fed's lead. And the Feds decide, like, we're going to do this temporary period after like health emergency, keeping some of these around for a year or two. I can see states mirroring that as well, doing that, saying, like, we'll keep around some of the temporary things after the pandemic just to gather more data. We're probably going to see more regulations to try to clean up some of the vagueness that have existed before around telehealth. And then there may be, I warn folks, there could be some rollbacks in some states. So New Hampshire introduced a bill where they were rolling back some of like the temporary changes or like not making those permanent. And California, which actually had one of the most progressive telehealth Medicaid policies before the pandemic, has introduced proposed changes that roll some of those back as well. So there could be sort of a shrinking back too for states that have been like very, very progressive and generous with their telehealth policies to like, kind of like bring that more in narrowly as well. So that is it. These are some resources and some links. And I think we've got some time to take some questions, Kathy. Thank you.
Thank you, May. We have a ton of questions, so
okay.
Hop to the first one. What are the recommended steps that we can all take to help policymakers make decisions supporting telehealth?
First off, I think they need to know that you're out there and that you are very concerned about this issue. It's been interesting. So in the early days of the pandemic, I actually got a lot of calls from policymakers who were not familiar with telehealth, and they were calling me asking me things such as like, I got a call from a constituent that said that, their kid could not, who got sent home from college, can't access their provider from their health center, their student health center now, because they're in a different state and they're not licensed. Is that true? And it was from policymakers who never heard from before, who probably didn't have any issue, any interest in telehealth, maybe, until a constituent brought this issue forward to them. So I think first off, they definitely need to hear, you need to talk to your representatives and hear the story, and they need to hear the impact that these waivers have had. If you are a community health center, what has been the impact of you being able to provide your services to your patients? What's been the impact of those patients? The type of information that I think also kind of has not been made clear to them is, what would be the impacts if these things were rolled back. And if you happen to serve low income or rural communities or communities where of people of color, let them know that this is the population that you are serving. And maybe if they are using audio only phone because that is the only way to get in touch with them, you could create exacerbate more disparities if you get rid of certain policies such as audio only phone as well too.
Great, thanks, May. Next question is, what criteria do you expect will be considered by legislators in making the decisions on post-COVID reimbursement?
So, like I said, and again, this is just me doing a guessing work here. So nobody's giving me any inside track on things, but I'm just sort of what was said at the hearings, the fact that certain opportunities were not taken, the MedPAC report, those things is just making me think that there's just a lot of focus on cost. So, the fiscal side of things have been I think an influence on it. And also the concern of is this good enough? This was not a federal hearing, but it was a California hearing that I was at where they were looking at the California proposals. And one policymaker just kept hitting upon two things with audio only, which was, you can't convince me that a phone call should be paid the same amount as an office visit, and you can't convince because that they are comparable, and so they shouldn't be paid the same way. So there's two elements in there. It's sort of there's the cost concern of it shouldn't be paid the same way, but also the quality concern of it's not as good as in person. And I think those are the two things that stick in a lot of policymakers' minds is there's the cost concern, but also the quality concern. And one thing that I got a little bit frustrated about, both with the California hearing and the Energy and Commerce one, it was that the witnesses that they had there, I don't think relay to the policymakers that some of these concerns that they are raising already have built-in checks and balances in the system. In that, for audio only phone, I'm just hearing that policymaker in my head in California just keep repeating this, saying that he asked one witness who couldn't really answer the question because she was not a billing expert, or knew billing very well. We're saying so you're telling me that if I have a patient and I conducted surgery on them and then I did a follow-up visit with them on the phone and it was 5 minutes, that should be paid at the same amount as an office consultation visit and everything. And she tried her best. She said well, if it could meet those parameters of what an office visit was, I said yes, they should be paid. But that scenario that he laid out there would not have happened regardless if you did it via telehealth or in person or thing, because he was talking about a surgery and that's a global payment type of thing. It would have been included in that. So that's what I mean by, I think there are certain already checks and balances in the system that policymakers aren't aware of. And at least for those two hearings, they did not have the right witnesses to relay that information to them. That I understand your concern, it's valid, but there are already, unrelated to telehealth, elements built into the reimbursement system, both on Medicare and Medicaid side, that you are not allowed to do that anyway. So it's not going to change with telehealth, whether you do it via audio only phone or live video or in person.
Great. Next question. Are more health plans reversing their telehealth coverage post-PHE?
So for commercial plans, I don't know if all of them are, and part of that is because they don't share with CCHP like all of their policies. This has been sort of a sort of a running thing since CCHP has been doing this. Some health plans are very open; they like put their policies on their website, and or you call them, it's like, sure, here it is. And others are very, I don't want to say secretive, but they're a little bit more guarded in like their policies and like who they share them with, because that's proprietary information there. They don't want competitors to get it, et cetera, et cetera. So I don't know the extent of what all the health plans are doing. I will say that there are some health plans who are a little bit more expansive with their policies than others. I will also say, kudos to a lot of health plans at the beginning of the pandemic. A lot of them simply did expand their telehealth policies without any kind of nudging from like lawmakers. So there was sort of at least like that openness to it, but I can't really say if it's most or if it's like 50% or if it's 30. All I can say is like I know some have been a bit more expansive with it than others.
Okay, next question. And I'm not sure what the context of this, but it says, do state laws trump federal laws?
Depends. So sort of rule of thumb here is if there is a federal law that exists and you have a state law that conflicts with the federal law will trump. If you have a state law where federal law is silent on, the state law would apply. If you have a state law that goes further, that's more protective or than like federal law, and it does not conflict, then the state law will prevail. So for example, let's say for HIPAA, for that last one, if you're trying to understand what I mean by that, for HIPAA, you have HIPAA is a federal law. It's the floor. You have some states that actually put more protections on protecting health information, and that would be like, they're more protective than what HIPAA is. And as long as those laws don't conflict directly with the HIPAA law, those laws will then, exist because they take it a little bit further than like the federal law there. So that's kind of your rule of thumb and like how the state federal laws kind of interact with each other.
So CMS does not reimburse RHCs and FQHCs for remote patient monitoring, yet the FCC is funding RPM programs with no way to be sustainable after the funding. What needs to occur to get CMS and the FCC on the same page?
So for remote patient monitoring, that's actually Kathy and I have had many discussions about this, and TRCs have had many discussions about this. When there are like pilot programs or programs funded by different agencies, they may not necessarily understand what the reimbursement policies are with Medicare, and they may not take in consideration like, what exists out there, not even just with Medicare. You may also be talking about Medicaid state programs as well for like sustainability. It is something that is been frustrating, I think, especially for grantees of like, yes, we apply for this, but there's no way to keep this sustainable unless there's been like a major policy change here. What will need them to get on the same page? Part of it is education, and the problem has been, and it's just, you think of the federal government, huge. So you do in a lot of times see federal departments act in silos from each other, so they're not quite sure what the other department's doing, and they're not sure of the other policies. Um, one thing to like get them like on the same page is I think there should be like a little bit more attention sometimes paid to like comments that people write to, because I know CCHP has done this for like providing comments back on like proposed pilots where the FCC has like proposed pilots, and I'm sure we're not the only person who have pointed out like you may run into this issue when you're doing this type of pilot, that it may not be sustainable because of certain policies there. So, you keep taking that more into consideration. I mean, the easiest thing would be to just allow FQHCs and RHCs to be reimbursed in the Medicare program, but that will need to, first, you're going to need Congress to change that to allow them to like have that ability, or you will need CMS. This has been like a gray area with FQHCs and RHCs because I think CMS is relying on more of an administrative role. There's debate on that. CCHP and I know others have had like conversations with CMS saying like, we think you got the flexibility, but they don't think they have the flexibility to allow for a little bit more expansive utilization of these other modalities for community health centers. So they may feel more comfortable if Congress did something specifically and say like, we're allowing X for these things. So that may be what they're holding out for.
Interesting. So relying on the exception to the Ryan-Haight Act arising under the public health emergency, and this is a hypothetical, Dr. A treats patient B with controlled substances during the public health emergency. The PHE comes to an end. Dr. A still has not examined B in person. Now that PHE is behind us, in my hypothetical, must Dr. A discontinue prescribing for B unless and until A sees B in person? And if so, is A liable if B decompensates after A stops prescribing?
I'm going to assume this is because the patient is not going to fall into one of the exceptions like B in, that they go to like, let's say a clinic that's a DEA registered facility or with like a doctor, physically with a doctor or a provider who is like DEA licensed. So I'm going to assume it's not going to fall into one of the other exceptions there. So will they still be able to do it? This is kind of like that weird sort of gray area where it was not clear in the law, because it sounds like you've made the prescription, but maybe all you're doing right now is perhaps just refilling the prescription or renewing it. So the question is that if you're just doing that and what you did before was totally legal, can you continue to do that? And the Ryan-Haight Act is a little fuzzy on that of like, what happens with those refills. But then if you change the prescription, probably then they would need to fall into the other exceptions there, because now you're doing like a new prescription there. But it is a fuzzy area of the Ryan-Haight Act. But one other thing I want to point out, there's another exception in the Ryan-Haight Act for this, and that's the telehealth registry. So with all the other exceptions, like the public health emergency exception, the being with like a DA registered provider during the telehealth interaction, there was another exception called the telehealth provider registry that the theory is if you get on this registry, you're a good actor, you're a good egg, you're fine. You went through all these like, checks and everything like that. So you did not have to go on, utilize one of the other exceptions because you were on the registry. That registry was supposed to be, they were supposed to have final regulations in place December of 2019. It still has not happened. So that is something that the DEA needs to be pushed on to them to like do it, like do this final registry so that it can like, be implemented. And that's yet still another route that providers can do when they want to prescribe via telehealth. So if the earlier question about, what can you do when like talking to your representatives, mention the DEA registry, because Congress had directed the DEA to like have that final regulation out by the end of 2019, December 2019. They haven't even issued like proposed regulations yet. There's like nothing. And this was a directive from Congress, and I think they've kind of forgotten about it. So you might want to like just sort of like put that out there as a reminder saying like, you had given DEA this order here, so why isn't anything happening? That would be like another alternative that telehealth providers could use. If like they get on the registry, then they can like prescribe. They didn't need the public health emergency or one of those other narrow exceptions. Now, the one thing I would caution about the registry though is like Congress, I think this was short-sighted, did not tell the DEA how they were to construct it. So even though no proposed regulations come out, the DEA can make it so onerous that, telehealth providers could just sort of like throw up their hands and say like, that's not worth the effort to get on there. So, but it doesn't even exist yet. They haven't even done like draft regulations or released them publicly. At least I think they may actually have them internally, but they've never released them.
And that's been an ongoing issue for
like
quite a few years now. Yeah.
Like that. Yeah. It's been like forever. And then finally Congress ordered them and then they didn't even release anything. It's like, what's up with that?
So along the same lines, what House or Senate committee should the grassroots target in terms of providing education and recommendations to make certain parts of the waivers permanent?
So Energy and Commerce, we know that was the one on the House side. And on the Senate side, it's the Health Committee. It's Health, Education, Labor, trying to remember what the P is. It's help is what they call. So those are the two committees you want to target. I know Senator Patty Murray from Washington is the chair of the one on the Senate side. And I know her staff has some familiarity with telehealth. So definitely those would be, and target both parties. Like I said, has bipartisan support. I think a lot of like kind of the stumbling block of it too has been like there's just been a lot of stuff going on that they've just been addressing that's unrelated to telehealth. But I think it needs to be elevated a bit more in their minds because it's become like so integrated in our health system, and if it goes away you do impact, I think, a lot of vulnerable populations.
So here's an interesting question for an attorney. Sounds like telehealth should not be practiced or used without close consultation with an attorney specializing in telehealth policies. Is this a fair statement or a prudent approach?
So as not legal advice, let me put that out there. So as an attorney, I always say it's good practice to just consult with an attorney just to be sure as a safeguard and everything. Do you need one to like completely practice it? Kind of depends on what you want to do. So it kind of depends on like, what telehealth you're trying to do. It is complicated. I won't lie. It is complicated to navigate sometimes. I would suggest actually your first step maybe to talk to your telehealth resource center just to like, get a grounding. So look, this is what the telehealth resource centers are there for, is to help you help you get grounded. If you are new to telehealth, if you're starting to like have that be an aspect of your practice or just start a telehealth program, talk to your telehealth resource center first to get grounded, to understand what questions you need to ask, what you need to like look at first. So that's what they are there for. So I would say actually your first step is talk to your telehealth resource center to get a better idea of what you're trying to do and where you need to look before you go off and hire anybody. So I know like people have hired consultants or they've hired like marketing firms and everything. It's like, check in with your telehealth resource center first, just to see if you really need any of that, because it's going to kind of depend on what state you are in, who you're looking at for your providers, or your Medicare, Medicaid, commercial payers, and also like what you're trying to do.
Right, we have a comment as well as a question. It says, great talk, May. Could you please comment on the potential inclusion of telephone-only visits being considered telehealth post-pandemic, and if this is a good thing or a slippery slope, specifically from both the patient perspective and quality perspective?
Yeah, so the general thought that CCHP usually has is that the provider in consultation with the patient really is the decision maker on what modality is best to be used, because the policymaker, me, Kathy, we're not there at that particular time for that particular episode with that patient. So really it is the provider and patient who knows best what should be utilized at that particular moment. So if they think audio only is appropriate to be used, that they should have that flexibility to use it. Now, is it a slippery slope? Again, the issue is like you should allow the provider to exercise their professional judgment, knowing the particular facts of the case and also the willingness of the patient. If the patient says, I don't want to do this by audio on phone, of course, don't do it that way. But also there is also the practicality of it, in that it might just simply be the only way in order to like get somebody some type of service. I mean, that was definitely what we saw during the pandemic. And are you unfairly like impacting certain people? And it could be like, it could be a wide variety of people. It could be like seniors, it could be people in rural area where that is their only option to like receive some type of service too. So you need to balance all of those things as well, because I'm glad that there was additional money in the Consolidated Appropriation Act for broadband, but let's be honest, that broadband problem is not going to be solved for everybody within the next year. It is going to take a while to do that. So what do you do in the meantime until everybody does have like high-speed broadband access where they can use video? Do you make them go without? You may audio only may be the only option that they have, at least for some of their services. Now, is it for every service? Absolutely not. Same thing with telehealth. It's not going to be like utilized for every situation. It's not appropriate for every situation. For those situations where the provider thinks it is appropriate, where the patient is willing to use audio only phone, they should have that flexibility to do that, because it may be the only option for them until the broadband issue is solved, because I don't think the broadband issue is going to be solved within the next 12 months. I would love to be proved wrong. I would love everybody within the next 12 months to have like high speed internet access where they can use like live video, do telehealth that way. But I'm pretty sure I'm right that it's not going to be solved within the next 12 months. So you've got to have another alternative there for those people who would otherwise go without.
Great, thanks, May. And I think we have time for one more question. So there has been discussion of payers' coverage of telehealth when appointments are preferred by patients but not required medically. Any thoughts about this?
So is this question not required medically but preferred by patients? Is this sort of getting at like the whole
whether those visits I think should be reimbursed
in addition to or something like that? Yeah, I mean, I know this has been like a concern, I think, because there were, before the pandemic, there were some commercial studies where they said like, oh, it's not been a replacement for in-person services. It's been kind of an add-on. So that's why you're going to increase your cost of the system. So if that's where the question is going, I don't think that we definitely did not see that during the pandemic. So there was like that one-to-one replacement in a lot of cases. It was not like, that add-on that we were seeing before pandemic, which we didn't really see widespread. We just saw like a couple of studies for some commercial payers. And I don't question their findings, but what I question is like, well, how did you set up your policies on that? In that, did you create this environment where it was sort of like this, oh, hey, I could easily set up an appointment, go see my doctor in person for something, but I'm just being lazy. I'll just do this as an add-on to like check something that, I may or may not be worried about, like maybe a skin rash. I'm pretty sure that's just like, a skin rash, and maybe it'll go away in a couple of days, but I'll just do that. And then maybe I normally would not have done that if the telehealth option was there. I just kind of wonder, like with those studies, like the findings of like, but what were your policies that you had set up? Did you create an environment that allowed that to be used more as like an add-on, as opposed to like it was going to be a one-to-one replacement? So that would be my first thought of like, we could probably craft the policies where it does happen more of like a replacement for an in-person visit, so you don't have like, what I think policymakers may fear or commercial payers may fear, like increased cost, because this is considered like an add-on to like, what normal care or something, or typical care, instead of an in-person replacement. I hope I answered that question, if I'm like understanding your scenario correctly.
All right, well, thank you so much, May. Appreciate your time. We do have more questions, so if you don't mind, we can try to send those to you by email and have you just write out some responses, and we can upload those to the app and just put a document on there with those responses.
Yeah, just go ahead and send them to me, and I'll try to get to them as soon as possible.
All right, great. Thank you so much. And we will move from here to just our wrap-up session and close out our summit. So if Jason, you could put up the slide set. So what we're going to do is just do a quick walkthrough of some of the frequently asked questions. So the next slide, things that we've been asked a lot: were all the sessions recorded? Absolutely yes. So if you bookmark the virtual event platform, if you haven't already done so, all the session recordings will be posted within 2 weeks, possibly less. So you just need to go to the session and it should look like this. Some of the recordings are already up from the pre-summit sessions, and you'll be able to then just play the recording directly from the session app. Are all the presentation slides available? Almost all of them are. So some presenters did not give us permission to distribute. Some presentations had research that was still pending and not published yet, so we could not disseminate that information. But anyone who has given us permission to provide their presentations, those are already up. Now, I have to say that we had a couple of presenters, actually more than a couple, who updated their slide sets within the couple hours before their presentation, and we have not updated the mobile site yet with those updates, but give us a day or two and we'll get the most up-to-date versions on there. Another frequently asked question that I don't have on the slide, but it is, how do we contact people? So most people who have logged into the app, you can message them through the app. We also asked when you registered if you were willing to make your emails available. So if you have checked today, you will see that for those attendees who said yes in that checkbox, we have now a field that says email made available to the public. So if you go to their profile, you should be able to see their email address, and then you can email them directly. Um, for those of you who did not enable email, or maybe you said yes and you have changed your mind, you can go into your profile and just change whatever settings you want. So you can delete that field, or you can add your email if your email is not showing and you would like attendees to be able to contact you for networking purposes, or be able to talk to you as a speaker, or even if you are a vendor and you want people to be able to contact you and you never enabled your email. So that is all there. Next slide. So a couple things that we are talking about in terms of awards. We had a People's Choice Award for posters. And so our poster session was voted on by a lot of people. So thank you for being involved in that. And so for our poster award, if we can just, we are showing the poster. The winner is the Smart Glasses, a solution for the limitations to medical education brought upon by COVID-19. So congratulations to, I think it's Leica Devara. I think probably butchering your name, but we will be getting in touch with you to get you your award. So great job. And our next award was for our game prize. And the winner of that game, and it was a pretty fierce competition, I understand. We had a lot of people trying to compete for that one, but it looks like the winner is Thomas Corey, and so we'll be getting in touch with you to get you your prize. Congratulations. And then the next thing is just ask that you please be sure to complete your summit evaluation. We have added a summit evaluation. You'll be getting an announcement. You'll also be getting an email about that summit evaluation. We really want to do some quality improvement in terms of this. This is our very first time going all virtual. We would love to get your feedback on what it was like for you, what worked, what didn't work. We have basically talked to our advisory board, and there's consensus that we want to definitely go in person, but also offer a hybrid option. But we want to hear from you. Do you want to be all in person? Do you want to have a hybrid option? Do you want to stick with all virtual? Some combination of all of those things, and what worked and what didn't work well for you. So we also have in our summit evaluations opportunities for you to volunteer. So being able to put this on took a lot of people involved in a number of committees, everything from figuring out what's on the program and how do we, what speakers we should bring in, what topics are of interest. So we have a lot of opportunities to be on program committees, to be on outreach committees, to be on our exhibitor committees, to be raters for our awards and for our posters. So please volunteer. And so that's part of our summit evaluation. And then for our next slide, our next steps. So as we mentioned earlier, our kind of three-part series on reimbursement, during the PhD, kind of what you heard today about after the PhD, and then what we have our state regional meetings. We usually have those during our summit, but because we are all virtual, it's a little more complicated to try to schedule everyone at the same time. And so we have set up a series of state meetings. Those are in your app. And if you click on the tab for state meetings, it should show up all the state meetings that are on tap. Those state meetings, and you can go to the next slide, are scheduled throughout the month of April. All of the dates are on there. Delaware is still has just committed to a 10 a.m. time on April 23rd. If you are part of the GP track region, they're going to have a regional meeting. So all of the states that are part of the Great Plains Telehealth Resource and Assistance Center, that's on April 9th. And that one is on Central Time. Everyone else is on Eastern. Those state meetings are really about dealing with the state level challenges and opportunities for shaping telehealth policy and to tag on to what May was talking about, making some of those permanent or temporary changes more permanent if those are things that we want permanent. But we also know that some states did not go far enough. There were some things that people really wanted to enable to have better patient care, and states didn't really go far enough. And we want to talk about some opportunities to push the needle a little bit further in your states. So this is an opportunity for you to meet with people in your own states to really address some of these state level policy issues and to bring to the forefront things that you want to collaborate and work together on. So I would really encourage you to be part of that. And we will also be sending out an email to you by state. So if you signed up as Pennsylvania, you'll get one email from me that says, hey, you're from Pennsylvania. This is the Pennsylvania State Meeting. That one is coming up really soon, April 1st. So mark that time down. If you go to the event app, you can hit the links to those state meetings. So if it's a Zoom meeting, you can hit the link to the Zoom meeting for that time and date. So if you signed up and your work state was Pennsylvania, but let's say you actually live in New Jersey and you really care about New Jersey policy, you can go ahead and join that New Jersey meeting as well. You just won't get that specific email about the New Jersey meeting because you signed up as Pennsylvania, but all that information is accessible to you on the app. And last but not least, save the date. So on the next slide, our next Telehealth Summit is scheduled for Sunday, April 24th through April 26th, 2022, and we would love to see you there. And that is about it. Our final slide is that's all, folks. Thank you so much for joining us. Thank you for taking the time, and we really appreciate all that you have been able to contribute. And we look forward to seeing you next year or earlier than that at the state meetings and all the other things that we're offering. So thanks again, and thank you for being part.